Facebook, and we're here with Dr. Jon Stone. We'd like to welcome everyone that's here from wherever they're at in the world, and we're going to just open it up for Q&A. Typically, we try to shut things off within about 20 minutes. We're going to go ahead and run longer this time since there tends to be so many questions. We also want to remind everyone, if they would like to ask the question themselves, please, if you don't want to be on this camera, to turn off your video. Also, you can change your name if you would like to keep any comments anonymous. You can also use the Q&A at the bottom, so please feel free to ask a question any way that you feel most comfortable. So we'll start off with our first question, and it says, they ask, what do you look for in psychogenic bait patterns?
Okay, so yeah, functional gait disorder, it's a common problem. There are a number of quite typical patterns. One of the commonest is someone who has functional weakness of a leg, one leg in particular, and they're looking for a very typical type of walk where the person tends to walk with the front of their foot dragging along the ground. If someone has a stroke, for example, the leg will typically swing at the hip, whereas someone with functional leg weakness very typically tends quite commonly drags the foot with the front of the foot on the ground. So that's an example of how you make a positive diagnosis. Some people have a more generally unsteady functional gait, and there are a number of tests we can do. So, for example, discovering that it's actually easier for that person to walk as if they're ice skating or sliding along the ground, or sometimes people find paradoxically it's easier for them to walk fast or jog. It's easier to do that than it is to walk slowly, or sometimes walking backwards. So it's all about positive signs.
Okay, great. How much research and progress has there been since 1990s, which is when this particular VEER was first diagnosed? What has sort of changed during that time?
I think an enormous amount. My interest began around in the late 90s, and there was very little research going on. There was just the beginnings of interest, but most neurologists I spoke to just didn't regard this as something that was even within the province of neurology. I think we've come quite a long way since then in terms of the research and the science, and also developing neurologists' interest in the condition. So we're having a international conference next week in Edinburgh with 500 delegates, which I think wouldn't have been possible at all, even 5 years ago, probably. So I appreciate that on the ground, many people won't see that level of interest, and they'll still be where things were before in some places, but I think things are changing gradually.
Wonderful.
So John, we have another question about a gentleman that has been diagnosed with ME for 18 years and FND for 8. He's asking what support team should be in place for FND sufferers. And there are a few contact numbers and email addresses for the community, but he's asking whether or not that will improve.
Yeah, support. I think what we need to do here is actually use the teams that are already there very often. So, for example, in my area in Lothian, we didn't get new people as part of our team. We just the existing community rehabilitation team began to develop an interest in patients with FND and discovered they could help, and are now very enthusiastic in supporting them through treatment. So a lot of the problems that people face is not necessarily due to lack of staff. It's often due to those staff perhaps feeling themselves lacking confidence to help the person. But obviously, it is important that teams are aware of the sort of problems that people with functional disorders have, the problems people have with chronic fatigue, knowing when treatment will help. Also, knowing when treatment may not help, and that person may be in a position where they're trying to just maximize their quality of life. So, but those are skills possessed by rehabilitation teams, by neuro specialist teams in many places.
Thank you. Sorry, Bridget, did you want to go over the next question, or?
Well, I think the next question we have a participant asking is who you're working with to educate in the United States. And you were just fairly recently here. Can you tell us a little bit about some of the opportunities you've had in America to help educate some of our doctors?
Yeah, well, there's been a lot of cross-fertilization. So I've been honoured to be invited to hospitals in Boston, where there's actually a number of doctors who are already doing a lot of research in this area, and gave grand rounds and talked to the residents as well about this. Did something similar in Stanford recently as well, and again, a lot of interest particularly from the junior doctors, and liaising with a very good team there, doing some very interesting research using virtual reality. The US have been very receptive generally to this increased interest in FND. For example, I gave a lecture to the American Academy of Neurology a couple of years ago, and have written articles for their continuing medical education journal for their trainee neurologists. So I think we've still got quite a long way to go before this problem achieves the scope and range of interest that, for example, other similarly common conditions like MS have. It is as common as MS. So we've still got a very long way to go there, but things are improving.
I think what you're talking about, how important it is to educate across various countries so that we're all on the same page, it's so important. And yeah. I think as you're doing that, it's as slow moving as it's been. I think it's going to take off like wildfire. Do you kind of feel that same way? That
I think it is. I think what I'm seeing that's really encouraging me is that when people develop the skills to recognize and treat FND, what they discover is that actually you can't get everyone with FND better, but you can get some people substantially better, and a lot of people you can make their quality of life much better. And that actually, from a health professional point of view, is actually very rewarding. And I think what's happening is it's turned from something that doctors used to feel very negative about and think, oh well, perhaps this isn't my job, and I can't do anything for this person anyway because they haven't got brain disease, to actually this is a common condition that I can recognize and for which I have evidence-based treatments that can help, and can sometimes help dramatically. So I think I see that happening all over, that people are beginning to see that in pockets. It has to be said, but it's definitely spreading. It is.
Wonderful.
So one of our participants, John, has asked that it's very difficult at the moment to kind of get disability when a person has conversion disorder. Do you know what research is available to show that it is actually a disability?
Well, this is quite an easy one, really. Do we know if the person's from the UK who's asking?
Unfortunately, they haven't said. Yeah. I'm making the assumption, yes. So if the person would like to respond, USA, there you go.
Yeah, I think the rules are should be fairly similar around the world, but of course I don't know the rule. You know, things may vary from place to place, but certainly in the UK, and I've spoken to the national organisation that is in charge of this. You should be assessed on the basis of your disability, not your diagnosis. So unless someone is suggesting that you don't have that disability at all and that you're lying and can prove that you're lying, then you have that disability. The diagnosis really shouldn't make a difference. It's quite clear in the UK that FND should be regarded as a legitimate condition, but actually it doesn't really matter. It shouldn't matter what the diagnosis is. If you have problems with mobility, if you're having seizures, then that's what you're having, and if you're being assessed in terms of what you can do day to day, the diagnosis should not matter. In reality, I know what happens very often is that the assessors for these things hear that the diagnosis is FND or conversion disorder, and they may not understand it, and they may think, is that something that I should be assessing as a disability? Yes, they should. And quite often people are wrongly assessed, but those things are normally overturned on appeal, in my experience, although not, of course, not always. So that's I think how it should work. Whether it does work like that in practice is another matter.
I just wanted to ask, is everybody hearing us? I think we had somebody said that the sound had stopped, so I just wanted to ask if we're all okay and everybody could hear.
Okay, I hope everyone can hear me okay.
Yeah, it doesn't look like I've had any more, John, so I think we're good. So I think we have another question, which is, what is somatoform disorder?
Okay, yeah, so somatoform disorder.
Oh, somatoform, sorry, my apologies.
Yeah, no, I mean, it's one of many, and it is very confusing for anyone new to this area to come in and hear all these different terms. Although, you know, many conditions have lots of terms. So, you know, if you have epilepsy, you might hear the word seizure, epilepsy, grand mal, tonic-clonic. Somatoform is a term that's been around probably for around 30 or 40 years, and is a term used to describe patients. It's a psychiatric term, really, to describe people who have genuine physical symptoms that are not due to disease, and in which it's thought that psychological factors are relevant in the maintenance or onset of those conditions. What's happened with FND is that we've moved away from that kind of thinking. We're not throwing out the possibility that psychological factors are relevant in individuals, because they often are. But it's been recognized that in many patients, psychological factors are not as important as people thought, or sometimes it's not possible to find them. So I prefer not to use that term. I think it's a very rather narrow way of thinking about it. It also, it tends to suggest that the problem is all psychological, when I think that's a very much too narrow view of the problem. It's similar for somatization, would be another word like that, and conversion, which is an old word, it's 100 years old. That's the Freud came up with that, the idea that a person's converting psychological stress into a symptom. I think the evidence for that is quite weak, actually.
Thank you. We have another person wondering if they find that heat makes their symptoms worse. Is this something that you see typically as a trigger for other FND sufferers? Yeah,
that's interesting. I would be very interested to know where that person lives. Probably not in Scotland, I suspect. Do we know where they live? Because it might be that extreme heat would make things worse.
We don't know where they live, but we have heard of other members saying that heat does make a difference.
Yeah, I mean, people that I meet in Scotland, I mean, I'm from England, but people in Scotland, people will often say, I went on holiday to Mediterranean, felt a lot better. So maybe it depends where you live. I think changes in temperature can certainly make things, they can make things better or worse. I think heat tends to, a lot of people feel that their pain improves with heat. But if you live somewhere that's hot already and you're talking about extreme heat or humidity, that is very draining. It would make fatigue worse, and I would expect that would make a lot of FND symptoms worse.
All right, thank you. Go ahead.
Sorry. So we've got a lady that's saying that some GPs in Scotland unfortunately are not that great with FND. So is this something that you are also finding within Scotland, that GPs are just not educated enough with regards to FND?
Yeah, and I think that applies to a lot of health professionals. Um, I think we have to be careful here not to be too critical, because with those doctors who are who might be behaving in a way that comes across badly or negatively, were probably trained in a way that either just didn't probably had no education about this at all, or if they were told about it, might have been told given some ideas which we've moved on from. So I'm not critical of doctors who behave like that, but I do appreciate it causes problems. What I would encourage people to do is to try and be tolerant of health professionals who come across negatively. Try and educate them when you see them. Explain that there is information, research about this condition, and I do appreciate that's difficult, but that tends to be more constructive than just feeling upset. But I do know it happens. I'm aware that there are still lots of negative attitudes out there, and sometimes that's from lack of knowledge, and sometimes it's just a negative attitude that people have.
Dr. Stone, I think you mentioned a good point about helping to educate their doctor. How would you say would maybe be the best way for them to do that? Would that be printing something off, just giving them a website? What do you think is the best way as a clinician? How would you, to receive that type of information?
Well, ideally you have a neurologist or a doctor who's written a letter about you to your GP and explained that this is the condition you have and this is why you're making the diagnosis. And ideally you have a copy of that letter. So if your doctor hasn't given you a copy, you could ask your own specialist for a copy of the letter so you can see what they've said about you. And yeah, sometimes a fact sheet can be helpful. Obviously, busy GPs sometimes they can sometimes, I know, not seem very receptive to people waving bits of paper at them. I think it's just about going slowly with them and not getting upset. Even if you have reason to be upset, try not to be. Talk about if you've had a positive experience in hospital or with a therapist. Talk about that and let that doctor see that you are happy to have this condition. You are looking for treatment. You're motivated, and all you're looking for from that person is help and support to do that. Sometimes the other reason that people come across negatively is they feel that they're not sure what to say, and if the patient can help a bit by coming across in a positive and motivated way. I know that's very difficult for a lot of people.
Great. We actually have a question now from one of our participants too, and so we're going to have Beverly.
Oh, I'm sorry. I don't have a question.
Oh, okay. We thought you had a question.
It just clicked on.
Okay, Beverly just wants to
see you in Scotland.
Is that Beverly from San Diego?
Yes, it is.
Hi, Beverly. Hi.
I just found that there are women in the Naval Hospital here that have what they're calling conversion disorder. Do we have any bridge that's going into the military? Because in my thinking, they're going to have some funding to research this.
Yeah, that's an interesting idea. I mean, there's a very long history of interest from the military in this area. So when soldiers by the thousands had symptoms, essentially they had FMD in World War I. It was called shell shock, and there was a lot of interest. It's come and gone. There's been a lot of interest in other similar illnesses, so the Gulf War syndrome, over which there's been a lot of controversy, but I think there's a lot of lessons there for FMD as well. I'm not aware specifically of a military research program, but in the UK, there's quite strong links with those people interested in FMD, like Sir Simon Wesley, who's speaking at our conference, and military health. So yes, if you know where to get hold of any military money, I'd be delighted to talk to someone about that. I think it is. I'm sure it's quite a problem. I know of studies looking at dissociative attacks, dissociative seizures, also called non-epileptic seizures, in veterans. Quite a high rate of those of FND after injury. So people have a mild traumatic injury, or sometimes a mild traumatic brain injury that should improve reasonably quickly, but they're left with FND afterwards as a legacy of that.
Thank you, Beverly. Thank you, John. We have another question regarding any programs within Ireland. Are you aware of any that are due to commence?
Oh, sorry, lighting. I am actually, someone just emailed me from Dublin to say, could they use some of my material in their, because they're getting together some material for their patients with functional motor disorders. It was a physiotherapist. So I don't want to sort of advertise because they might not be ready, but that was encouraging. I'm not aware of, I'm going to get this wrong, but I'm not aware of a specific neurologist who's with a card carrying interest, but I have spoken in Cork and they were very receptive. I'm also going to Dublin at the end of the year. So I think things are hopefully moving on there.
Perfect, thank you. No, it sounds promising, which is great, which is exactly what we need. We've also had another one regarding gait again, but have you ever seen someone with scissor gait when they have FND?
Yes, so that is a gait that we recognise can occur with FND. Usually that's a patient who, so scissor gait was actually initially described as a type of gait that people with cerebral palsy had, because their legs were sort of bent at the knees. But some people with FND, particularly those who get functional dystonia, and that's where there's spasms of the muscles so that the knees turn in a bit, and sometimes so they turn in at the hips, out at the knees, and in again at the ankles. And if someone who's got functional dystonia in both legs is walking, that can look like a scissor gait.
Perfect. We've also got one regarding emergency rooms. They said, how would you kind of help the people that are kind of helping you in the emergency room to kind of understand FND?
Yeah, well, that's a good question, because there's a lot of people with FND, acute FND, going through emergency departments, patients presenting with seizures in particular, and with stroke-like episodes. So about 50% of patients brought to hospital who are shaking all over, who the ambulance driver thinks is having an epileptic seizure, is actually having a dissociative seizure. So it's actually really important that they can tell the difference. I think that's something that is improving, but we've still got a long way to go. I know that I've lectured I've been invited to speak by acute medicine and A&E groups who are interested. They are very keen to get the right diagnosis and give the right treatment. There is increasing interest in making this diagnosis much earlier in patients who present with apparent stroke. There's a big study across lots of acute stroke units in London showing that up to 8% of patients presenting to acute stroke units had FND, and pointing out that quite often they were misdiagnosed actually at the beginning. These things just are, again, they are improving. I think what one sees in the literature is the percentage patients recognised as having FND is increasing. And people are more willing to make the diagnosis earlier because they want to give the right treatment. And they don't want to if you give someone with a dissociative seizure drugs for epilepsy, it can make it worse, in fact.
Thank you. Talking about, I think we had another question regarding diagnosis. So we've had a participant say that they've actually been diagnosed with FND from their GP. But can a psychiatrist also diagnose FND?
Sometimes it depends. Yeah, it really depends on the symptom. I mean, most FND symptoms are neurological by definition, And whoever's going to make that diagnosis needs to have a good knowledge of neurology. So now that there are psychiatrists who work very closely with neurology and have a lot of training in that area and can make that diagnosis, particularly neuropsychiatrists or liaison psychiatrists. And sometimes a GP will, a GP may well be correct about diagnosis of FND, but it's as a general fallback position, I would say that you generally want a neurologist to have a look at that diagnosis. I would say in most cases, but not all. And it's more about the expertise of the individual than their specialty, I would say.
Thank you. We've also got a question regarding, so we've got a gentleman that's been diagnosed with generalized anxiety disorder symptoms.
Yeah.
And his question is in relation to CBT therapy, which is what is he supposed to try and avoid with CBT therapy when his symptoms are random and he doesn't really know what those identifiable triggers are?
Yeah. That's a good question. So I think what I would say there is that this is one of the things that's maybe changed over time. So people used to think that when people had symptoms, if they had a seizure or if they had an episode of paralysis or the symptoms got worse, that there must be some form of trigger and that you should look carefully and work out what that is. And in some people, there are triggers. They have, if they walk down the stairs, they find that they're more likely to have a problem, or their leg gives way in certain situations, or if they get stressed, the symptoms get worse. But actually, in most patients, I would say that it's very hard to find very specific triggers for symptoms coming and going. For example, with seizures, we often find that people are most likely to have dissociative seizures when they're sitting on the sofa just watching the telly, doing nothing, often when they're sort of staring into space a bit and they're not really concentrating on anything, and they're more likely to sort of float off and dissociate. So you could argue that is a trigger, but it's not necessarily the one that people are looking for. People often looking for stressful triggers or being asked to, and then feeling a bit annoyed and frustrated when people keep going on about that. And sometimes these symptoms really are just random. It's a bit like looking for triggers for migraine. Some people have migraine when they're stressed. Some people have them at the weekend when they're relaxing. Some people just have a migraine whenever it damn well pleases, whenever it wants to come. So
yeah,
accepting that randomness and trying to work with it is very important, I think.
Okay, thank you. We've also had another question regarding, have you ever heard of MDMA assisted psychotherapy for FND, and what's your thoughts on that?
I have vaguely. I mean, it doesn't sound like a good idea. I assume that's MDMA, which is the methyl sort of amphetamine. Is it? I don't really know. I better be careful.
I'm not sure. Unfortunately, the participant has just given me the very short code. Yeah. So I'm not sure.
I mean, that MDMA, as I understand it, is a form of amphetamine, and I think there's interest in various medications that might enhance treatment. I'm not sure about psychotherapy under the influence of drugs. I think it would be rather better to try and talk to people when they're not having a strong drug. I think that there is some. I've published on a technique called therapeutic sedation, where for people with very severe FND that we can't get into any other way, giving people a sedative anaesthetic and to put them in a sort of altered state, with the benefit of an anaesthetist, obviously, and to use that altered state to try and help reset the brain, reboot the nervous system. It's sometimes helpful, although there are no quick fixes in FND, really.
So keeping on the kind of medication, we go on to looking at the relationship between vitamin D and vitamin B12 deficiencies. Do you find that association with FND?
I don't think anyone's done a sort of a proper epidemiological study. Measuring vitamin B12 in particular, it would be a standard thing for a neurologist to do in anyone with well, most patients with neurological symptoms, because it can present in various ways. So it's important to make sure someone's B12 is okay. It's important to say it wouldn't cause specific symptoms of FND itself, but it might be something that might cause a vulnerability to FND, and I've seen that. Vitamin D, most people in Scotland have low vitamin D. There's not enough sunlight here. And it does cause problems with osteoporosis and fractures and things like that, but it doesn't specifically cause neurological syndromes. So like most things, it's important to make sure that your body's healthy and you've got enough nutrients. And it would be lovely if you could fix FND with correcting B12 and correcting vitamin D, but you can't. But it's important to look anyway, treat if it's there.
Lovely, thank you. We've got a question by a lady that says, at what point do you diagnose psychogenic seizures versus things like illness, low glucose, slip disc, loud noise, light, etc.?
Sorry, versus?
Versus things like illnesses, low glucose, slip disc, loud noises.
Loud noises, okay. Well, so the diagnosis of, they call it psychogenic seizures, which many people use, or dissociative seizures, which I would prefer. Again, it's a positive diagnosis, so it's not, many doctors still think it's all about just making sure you record a seizure and showing it's not epilepsy or a faint. That is sometimes helpful, but what you're looking for are clear features of the attack, which we know only happen in dissociative seizures. So, for example, someone who has a sudden fall to the ground, lies still and is unresponsive with their eyes closed, and you have to have all those components for a couple of minutes, is almost certainly having a dissociative attack, because there's nothing else in medicine that produces that combination of features. If you have a faint, you would fall down suddenly, but your eyes would be open and it wouldn't last 2 minutes. People who have dissociative seizures will often shake, and if they do that with their eyes closed, and the shaking and the arm and the limb movements are clearly those of a tremor, then that's typical of a dissociative seizure, not typical of anything else. So we need to get away from the idea that these are diagnosed because the tests are normal or because the glucose was normal. It's because they have their own features. It may be that it's important to make sure that the glucose and other things isn't going to be an issue or isn't involved as well. But it's not a diagnosis of exclusion. And it's the same for a slip disc or any other condition. For motor disorders, they've got their own positive features, which can be present even with a slip disc.
Lovely, thank you. So we have another question regarding speech. Can speech be affected in FND? And if so, what are those particular problems that we see?
Yeah, so it can, very commonly is. You can divide them up very broadly into problems with articulation. So symptoms like slurred speech. Patients may say that their speech sounds drunk, as if they're drunk sometimes, even when of course they're not drunk. Stuttering is quite common. So stuttering is an example of a symptom. It's very unusual as coming from a brain disease, but quite common as a symptom of FND. Occasionally people develop an altered accent, so-called foreign accent syndrome, and we're doing some research on that at the moment. The other, perhaps even much more common problem is dysphonia, where people develop a whispering or very quiet speech. Often that follows on from a sore throat. The sore throat, the virus goes, but the person's left with the same problem that they had when they did have a sore throat, and that can go on for a long time. So yeah, very, very common, and actually, again, identifiable on the basis of positive features.
Lovely, thank you. We've also had somebody say about obviously hot weather, but we've had somebody suggest that also cold weather can also affect their symptoms along with migraines. Do you also find that as well?
Yeah, I think where I work, what patients with migraine commonly notice is a change in sort of barometric pressure. You know, when there's a storm coming or something, people will often find their more likely to have a migraine, and there's a very tight linkage in many patients between migraine symptoms and FND symptoms. I commonly diagnose migraine along with FND and look at that interaction. Arguably, migraine. I mean, I have quite bad migraine. I would regard that as a functional disorder that I have. And weather, I think, does interfere with it. It's probably more about a change. I think it's the body's ability to change to anything, hot, cold, differences in sleep becomes reduced in these conditions and in functional disorders in general.
Thank you. The next one we've got is, have you ever come across somebody that walks like they've just come off a horse? So their feet are very wide apart and very straight-legged.
Yes, I have, is the answer. Sometimes they're walking with their knees a bit bent as well, as if they've just come off a horse. And it's actually, what's interesting about that gait is that it's actually quite difficult. It actually requires very good nervous system to do that. Now, obviously, the people that have a walk like that are not doing it on purpose, but that's an example of making a positive diagnosis where, so neurologists would talk about an uneconomic posture. So it's actually walking like that requires additional muscle strength that isn't normally used. So that would sometimes be a way of diagnosing a functional gait disorder. There are many reasons why someone might walk like that, and functional gait disorder is only one of them, but it can be.
Thank you. So we're then talking about alternative therapies. Do you find any other alternative therapies that help with FND symptoms?
So I think my patients tell me about a lot of different alternative therapies they find helpful. Reflexology and hypnotherapy, which is, well, in fact, hypnotherapy is arguably not really an alternative therapy because there's an evidence base for it. So I'm not against alternative therapies. I just think there are therapies, and ideally, if a therapy is going to be offered or someone's going to promote a therapy, they should have some evidence to support that therapy. We know that you can apply most therapies to most conditions and you'll get some response. So you can give people placebo in an epilepsy trial and their epileptic seizures will get slightly better. So just saying that something works isn't necessarily good enough for developing a service. But if an individual finds a particular treatment helpful to them and it's not breaking the bank, then one shouldn't complain about that, I think. And often what people who administer alternative therapies are doing is something that patients can't get elsewhere, which is they're getting someone's they're getting the attention and skills of a therapist, often for a longer period, for example, an hour or so, which is actually very valuable. So I think a lot of the benefit of these therapies is sometimes to do with the personal interaction between that patient and their therapist. And I don't think there's anything wrong with that.
Lovely, thank you. We've actually got quite a few comments about people that are having CBT and they're perhaps on some sort of antidepressant, and they're finding that the CBT has been very, very helpful for them, which is good. There's also been people that have been seeing Glenn Nielsen for physiotherapy, which again they found very, very useful, and also any physiotherapy under Professor Mark Edwards as well. So I guess from your point of view, that kind of multidisciplinary type treatment care plan is probably the best way forward.
Absolutely. So that's another thing that's really changed, I think. So if you were looking at this condition, 20 years ago, which was one of the first questions we had, the sort of pathway, if there was one, which there wasn't actually, usually was patient sees neurologist and then immediately sent to a psychiatrist who was supposed to sort of treat the patient and often did their best but didn't really know what to do. I think we've moved on substantially from that now. We recognise this is a condition where we need a multidisciplinary team. We need the neurologist to be properly engaged, not just in diagnosis but treatment. We need physiotherapy, first and foremost, probably for people with functional motor disorders. We need psychological therapy, particularly for seizures. And then later, some people need both. You know, they need psychological therapy and physiotherapy. Medication may help. Other occupational therapy. It has a lot more in common now. It should do with pathways, for example, for people with multiple sclerosis who also benefit from, and stroke, who benefit from that multidisciplinary approach.
Do you find sometimes, as part of one of the questions that is raised, that they may go through this treatment, but potentially may have a flare-up later on?
Yeah. I think everyone working in the field recognises that these are conditions which often relapse. And in fact, really, for anyone who is, and that is one of the very difficult things to deal with as a patient when you have this condition, that you can find that you're 2 steps forward, 1 step back, or you might get better for a while and feel that you're really doing well, and then a few weeks later you wake up on a Tuesday and your leg's gone weak again, or you're shaking, or your walking's gone funny. So I think treatment should help people anticipate relapses. Patients don't want to hear that when they feel better, but I think it's often important, because then when you have a relapse, you can say, right, well, I knew this was going to happen. I'm not going to panic. I'm not going to get upset. I'm just going to take it easy today. I've now got skills to manage my condition that I didn't have the first time I had my relapse. And my experience is often that really helps, and people find that they begin to self-manage their own condition. They learn to manage the ups and downs. They begin to spot things that perhaps they were overdoing it a bit, and that's why they had a relapse. But yeah, it's definitely an up and down relapsing condition in many cases.
Okay, thank you. So we have somebody that's asked what actually got you interested in FND?
Yeah, lots of people ask me that. And particularly neurologists, because I was a bit unusual to begin with. I think there's a few answers to that. I had a stutter myself when I was growing up, and as many children do, and it did improve. But when I was a teenager, it came back. I think it was a little bit of a functional disorder then, probably. And I was interested in that. I had some dissociative experiences. I was growing up, and I had some sort of, they were pleasant ones actually, as children often have dissociative experiences, and I was very curious about them and what they were. I've got the sort of personality that fits being a neurologist. I think I like lists and detail. I like the puzzle of neurology. But it turned out I was really, when I came across patients with FND, I thought this is a problem that someone should be interested in, and it's also fascinating. So even leaving aside the fact there's huge numbers of people with it needing much more attention and treatment, it's also intellectually very interesting as well as a condition. How does it work that someone can't move their leg even though the bits are all joined up? So it's fascinating for me and very rewarding on lots of levels.
So we've had somebody say they appreciate everything that you do. So and I'm sure that we do as well. So so we'll go back on to specific triggers. So one of our participants is asking, is it more helpful to expose yourself to those triggers constantly rather than trying to avoid them?
I think that's a tricky one. That's a question for the person that's treating you, because it really depends what stage you're at, what kind of triggers there are. Generally speaking, yeah, if you've got a trigger for which is then causing symptoms, that does suggest that you're sensitized in some way to whatever that trigger is, whether it's the environment or whether it's too much light, or whether it's a thought or memory or something like that. And if you're sensitized to something, usually the answer is to try and desensitize yourself to it gradually. But it needs to be done gradually. You can't just flood yourself. Usually, it's a bit like if you've got a phobia of flying, going in a plane is not necessary, and then having a panic attack is not necessarily a good idea. So doing it gradually, it really depends on the person, but I hope that answers the question.
Okay, thank you. So we've had another one say that several neurologists thought that they had symptoms of MS. but tests, obviously results were shown as negative, and obviously they've now been diagnosed with FND. And I guess the question is, why do they suddenly think that you're having MS, but then actually once all the tests are negative, they then diagnose you with FND?
Yeah, that's a very common scenario. It's because MS is a disease that people worry about and they don't want to miss it. It causes multiple symptoms which can look very similar to FND. So in my PhD 15 years ago, I compared a group of patients with functional limb weakness and MS. I was struck by how similar they were. They had all their symptoms, they had fatigue, they had weak arms and legs, sensory disturbance. But the thing for those people who've been diagnosed with FND, they often feels very unsatisfactory. You think, well, you thought I had MS, and then you did a scan and it was normal. And now you say, I haven't got MS. How do you know? Maybe the scan's wrong. Maybe you just need to do a different test. Perhaps I have got MS. And the answer there is to come back to the positive diagnosis. So if you have got a weak leg, is the weakness in a pattern that's typical of MS? Or is it in fact in a pattern that's typical of functional leg weakness with positive Hoover sign, etc.? So I think most of the time the sort of dissatisfaction with that sequence of events can be put right by your neurologist explaining to you why he's diagnosed or she has diagnosed FND. And it should be positive. If it's not based on positive signs, then I would probably challenge the diagnosis a bit. I'll get myself in trouble there saying that, but I think that is how FND should be diagnosed. That's in the diagnostic criteria now. So I think that helps. Yes,
it does. Thank you. So I guess one of the questions, just leading on from your positive tests, is you mentioned the Hoover sign, or the Hoover's test. Sorry, is it something that you might be able to explain to us that we would then be able to take away and talk to our neurologists with, but in a simple way that people would understand?
Yeah, I'll have a go. Yeah, it's actually really important. It's really important to, if you've got this particular problem with a weak leg, it's really important to try and get your head around it. There is a video of me doing it on the limb weakness page of my website, Neurosymptoms, so you can have a look at that. Some pictures. Essentially, there's two things about it. One is, what in the Hoover's test, what you're asking someone to do with a weak leg is just keep their foot on the floor, and then the examiner's trying to lift it up, and they're saying to the patient, right, keep your heel on the ground, don't let me lift it up. And actually, if someone has a stroke or MS, usually they can do that. They can normally keep the heel on the floor because that movement doesn't become weak with those conditions, whereas in functional leg weakness, it often does become weak. So the person's leg can be lifted off the ground. And then what you do is you lift up their good leg, the other leg, and pressing on it and helping the patient to focus on lifting up their leg, you discover that the weakness that they did have is gone. So when you're lifting up the other leg, it turns out that the heel that was previously easily lifted off the ground has come back to normal and is strong. And what that's showing is that when the person's trying hard to make the movement, things don't work. And it's a bit like most things in the body don't work well if you try too hard to make them work. If you think about going to sleep really hard, it doesn't work. So when they're trying to make the movement, it doesn't work. But when they're focused on their good leg, the automatic movements come back to normal and demonstrate that there is potential for improvement. They demonstrate the nervous system's not damaged. It's not MS or a stroke. It's a problem with nervous system functioning, and that's why it's called a functional disorder. So it's something you really need to visualize, and I don't think I can show you on this phone tonight, but have a look. So I hope the video on the weakness page of the Neurosymptoms website is helpful.
That's lovely, thank you. So we've had somebody, so again, talking about kind of the diagnosing of FND, is there any kind of imaging that can help us diagnose FND?
No, is a simple answer. So okay. Because the imaging that we have is images the structure of the brain, shows us what it looks like, but doesn't and there are scans that show the function of the brain. It's called functional MRI, and there's lots of interesting studies looking at functional MRI in patients with FND, showing, for example, differences in people between FND and people who are pretending. But they are not those kinds of studies and techniques are really just for research. We don't really know how to use those for diagnosis. Patients are often quite keen for there to be a scan which shows their condition. I understand that, because you kind of want to see it. You want to see, well, is it there, and is it or is it me, you know, and to prove to other people that they have something wrong. And I understand that. I would say to patients like that, I don't need a scan to believe you and believe that there's a problem, and other people shouldn't either. You can't see migraine on a scan.
No, that's very true. That's very true. Migraine is the worst. So we talked about diagnosis. So talking about triggers. Can FND be triggered by illnesses and viruses that you've actually seen within your area?
Yeah, all the time. In fact, that's another big shift that's happened in thinking, I would say. So previously, again, there was this very narrow view that the only thing that triggered FND was a stressful event. And that does happen. I do see patients where that's happened. But we reckon that actually more commonly, FND is triggered by physiological events, physical illnesses. So things like an injury to a limb, or migraine, bad migraine that the person wasn't expecting and had perhaps some neurological symptoms with it they weren't expecting. Flu. For example, I had a patient who had really high temperature from flu and was shaking, as sometimes people do when they've got a high temperature. He was shivering. The virus and flu went away, but he carried on shaking, and that was a functional tremor induced by flu. Drug side effects sometimes. Panic attacks, very common. Someone has a panic attack for the first time. They don't really know what it is. They feel funny down one side, which happens quite commonly in panic attacks, and feels like they're having a stroke, and the FND just gets stuck with that trigger. So physical triggers are very important.
Thank you. Now, I don't know whether I'm going to pronounce this word correctly, so my apologies if I don't. We've got that somebody's been told that with FND, the amygdala, apologies, has hijacked the submotor cortex. Do you think this is true? Yeah,
so that's the amygdala. That's it. Yeah,
thank you.
Yeah, that was almost there. So the amygdala, yes, this is a question really about what's going on in the brain when people have these symptoms. I don't think we know for sure yet, but I think we have more and more and better, higher quality studies, and some of them have found some overactivity of the amygdala. That's a part of the brain, it's quite a primitive part of the brain that is involved in emotions and fear response, and it does a lot more than that, really. And the brain works as networks, really, so it's not really that one part of the brain controls another part. But I think there is some of the studies do suggest that people's brains are in a sort of altered state where there are processes which are interfering with the normal movement. And that probably is a state of brain overactivity, and that fits with what patients say as well, that they're almost, many people feel that they have to think really hard about their legs when they're moving, or their arms shaking, and it feels as if their brain's working quite hard. So we see that on some of these functional research scans as well, that the brain is overactive, and the treatments need to help people re-establish normal automatic movements. Most of the things the brain does, it does just automatically. I'm not thinking about my mouth at the moment, or I'm not going to think about when I stand up from here. I'm not going to be thinking about my legs at all as I walk out the door. But someone with FND is. So we're seeing scans that are in keeping with that, I think. But we've still got a long way to go.
So I think we'll just take a final question, if that's all right with you, John,
Yeah.
unless you need to go. But do you have any specific advice for muscle tension symptoms that you might be able to give?
Okay, I wonder where they're thinking about there, because you can have muscle tension symptoms anywhere in your body, really, and probably think about pain and spasm. People get muscular contraction headaches, which are a mixture of muscle tension and probably increased volume knobs in pain pathways. There isn't a simple answer. If I was going to give one straightforward answer, I would say better ways of moving, I think. And
Okay.
I think my experience is that physical treatments that involve movement and moving differently seem to be produce much more long-lasting benefits than pills or painkillers, or and there are things which produce short-term benefit, like heat pads and massage, but I think they tend to produce short-term benefit, and then everything just comes back to where it was. I think people very often need to change the way they move, change their posture, change the way they're using their muscles, and that's difficult. It takes time, but it's possible.
Thank you, John. I really appreciate it. We do have some more questions, but we'll take those away with us, and maybe we can ask them the next time that we have a webinar with you, so that we don't lose them.
They were fantastic questions, by the way. That was a lot
Yes.
of very good questions, very challenging.
Another wonderful question.
Helpful.
You know what? I think we should leave with one last one, though. Someone's asking what your favorite color is. We can't
Yes.
leave
Color.
No?
It's green. I think it's green. Yeah.
Great.
That's.
Okay.
I think that's why I had green on my website, because I thought that was a relaxing color to look at. So I like green. Yeah. I've got a
Fabulous.
park outside my house, which is very nice. Trees and parks.
Fabulous. We also want to just remind everyone that they can maybe let their doctors know that there is a motor retraining for functional movement disorder that's going to be happening October 6th through 7th, and some of that information is available on the FND Hope website. That is in America, and that's with Dr. Lefevre. But coming up very soon, next week, is the big FND conference, and I just wanted to ask about how many attendees did we have last year at this conference, approximately? Do you remember?
Well, we had one, Bridget. So, I mean, there was the last time we
It
had
was the third.
Oh, sorry, the Atlanta one, you mean?
Well, I was meaning, because it said that this is the third annual FND International.
It is. Yes, so we have called it the third one, but that was because, well, there was a second. So the last one was in 2009 in Washington, and it was really, but it was focused on functional movement disorders. But we wanted to honour the fact that meeting had happened. There was one previous one in 2003, so shockingly long gaps between. This one is the first one to cover all of functional disorder, all of FND, not just movement disorders. Myself, Alan Carson, Mark Hallett have organised it in Edinburgh. We were a bit nervous about organising a big meeting. We thought, would people come? Would we lose money? I'm delighted that actually we've sold out. So we've got 505 registrations. I'm now a bit worried that it's going to be a bit full, but I'm absolutely delighted, because it shows that there are large numbers of people from all over the world willing to, come a long way, spend a lot of money to hear about FND. We've got a fantastic lineup of all of people who've been working in this field for the last 20 years. I'm really hoping that this signals a coming together of expertise in FND, and a desire. What it shows is a strong desire across many different disciplines to do better research, create better services, and to recognise this as a genuine common condition. So I'm very pleased about that.
And so are we. And we really appreciate all the work that you do to support FND Hope and our efforts, and we really appreciate what you do on an international level as well. And I think that conference just shows that while patients are struggling to find care right now, there is likely a doctor that is getting trained and working at becoming FND expert, hopefully, that's going to help them. And so I think it gives a lot of
I
hope.
think that's true. I think, as you say, it's spreading like a fire. Perhaps not a wildfire, but definitely spreading like a fire. Yeah.
Well, great. Thank you.
Well.
Yeah, and you have a great day, and we will hopefully have you again in a few weeks. So
Great.
thank you.
Be delighted to do that. Yep.
Thank you.